This podcast is sponsored by PAX. Whether on the water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. They're designed with infection control in mind and are easy to clean and disinfect. So highly visible colours and reflective strips aid quick identification and adherence to quality standards, ensuring reliability. So the versatility of PAX bags caters to diverse EMS providers, and they deliver vital equipment, durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations, and they're absolutely excellent, both in identification of kit, but also in identification of the reflective strips to ensure visibility. So please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about paediatric assessment with Dobbie. So assessing and managing sick or injured children is one of the most challenging aspects of care for pre-hospital clinicians. And it's also difficult because of the exposure or lack of, but also they have unique physiology, anatomy and psychological needs that demand a tailored approach. So in the episode, we're going to break down some of the key components of paediatric assessment, from the art of recognising some subtle red flags that may indicate a child is critically unwell, also exploring some practical approaches to the airway management, breathing, circulation and understanding what a good and indeed maybe foundational neurological status and assessment in children should look like. So we're also going to look at some of the softer skills around working with paediatric patients, like engaging with caregivers or parents, also managing children's fear, pain management, and also staying calm under pressure. So to do this, we have Dobbie with us. Anna is the lead clinician for London's Air Ambulance. As the clinical lead, she has certainly stewarded both culture and indeed a semblance of high-performing teams in LAA over the past 5 to 6 years. And it's fantastic to have her knowledge as an ED clinician, but also really with an interest in paediatrics and indeed time-critical sick pediatrics, and get her knowledge on the podcast. So welcome, Anna, to the podcast.
Thank you so much for having me.
Anna, I just wonder if we could start by looking at paediatric assessment. What are some of the fundamental things to keep in mind initially when assessing and treating sick children?
I think the first thing is to say is that we all get stressed or worried about going to paediatric patients. And I think we make so much of the potential differences, particularly between adults and smaller kids, that actually we forget how many similarities there are actually. And it's not like these small children are a different species. They are still physiologically human. And we have the skills to assess these patients. Particularly my specialist interest is obviously the trauma environment. And we'll probably talk predominantly about assessment in trauma. But I think it's really important to remember you do this all the time. And the thing about pediatrics is small kids don't lie. They show you what's wrong with them. They may not be able to talk and localize, but actually if you examine them carefully, you can work out what's wrong with them. And actually the joy of pediatrics is that you have a few more skills in your toolbox to be able to assess kids, as well as the ones that you usually use. And so actually kids are almost easier because you have more things to be able to use in your assessment to really find out what's going on. So I think just that degree of reassurance is this is familiar. This is very similar to what you normally do with just a few nuances, and just using those particular differences that we'll highlight as we talk to absolutely make your assessment completely 100%.
So how should we adapt and indeed maybe change our techniques and expectations based on children's age and development stage? Have you got any techniques you use to indeed help you tailor your approach to the age and development of the child?
Yeah, I think, you see these little charts that sort of say the average respiratory rate, the average blood pressure and stuff. I have no idea what the normal physiological values are. I just don't remember them. And so I always carry one of those little charts on my lanyard around my neck so that I can refer to them. And I think that's a useful idea because it can often catch you out. You know, you can see a pulse of 140 and you're like, oh gosh, and actually look on your chart and you go, actually, that's physiologically normal. So I would never recommend trying to learn, maybe having an idea of the sort of values of the parameters can go up to, but certainly make sure you've got one of those on and use it. There's absolutely no shame in referring to value cards and PEDS, aid memoirs for drug doses and stuff when you're doing paediatrics. And I think there's strength actually in checking your decision making and your calculations and things with aid memoir cards. So I would strongly advocate those. I think the other thing to think about is the children can pick up on how you're behaving and reacting. And we are all a little bit more on edge when we've got a really sick child in front of us. You know that the other emergency services on scene will also be feeling the same. There may well be parents on scene who are going through the worst day of their lives. And so just being aware of your facial expressions and a degree of calmness. I always say to people, actually, the small paediatric cases who are really sick are the ones to go just that little bit slower. Take a deep breath. Slow yourself down, calm yourself down, and actually you can almost go quicker by doing that. Take your time and do it once and do it well.
So looking at red flags, Anna, and just maybe some of the red flags that really stick in your mind for critically unwell paediatrics. How can pre-hospital teams really recognise these early, and what's your counsel when maybe mentoring and or signing off some clinicians at London's Air Ambulance?
Yeah, I think if you approach the scene, again, particularly from my area of trauma, and the child is still lying on the floor, that's a key thing. Just, just as simple as that, of just the child hasn't got up, isn't in mum's arms, is wanting to lie still. And if you think about all the children that you've seen in your practice, the ones that are really unwell or that have broken necks or broken legs are the ones that can't get up and do anything. The ones that get up, cry and give mum a cuddle generally don't have anything too life-threatening wrong with them. And that can be quite a reassuring sign. But the ones that are lying still or that abnormal cry, we've all heard babies crying and young children crying, but actually when they're really poorly, their cry changes. And if you've heard lots of normal cries, you'll recognize that abnormal cry. And there's just something about it that makes you just go, hang on a second, that's not quite right. And I think we'll talk later about the paediatric GCS, and abnormal cry is in that, and how on earth do you define that? But when you've heard lots of normal crying, there's something about it that you can just tell. It's a bit like when you look at lots of ECGs, you can identify the ones that are abnormal because it's an abnormality based on lots of experience of normal. So I think that's my two things that make me the most worried, is when I see a child lying on the floor still, or when I hear that abnormal cry. And those are my two things that kind of make me go, hang on a second, this is potentially quite serious.
What are some of the key considerations, Anna, when you're assessing and indeed managing a child's airway in the pre-hospital environment, certainly in critical care?
Yeah, we recently have just looked at a whole load of the paediatric cases, and we went to about 800 paediatric cases. So that was below the age of 16 over 5.5 years. And we actually intubated about 10% of those. So a reasonable number. But the reassuring thing was when we did intubate them, the intubations were relatively straightforward. And I think that's the reassuring thing to take away from this, is their airways are normally relatively anatomically normal. They don't normally have all the added complications of obesity or difficult scarring or things that we see in adults. And so the decision to intubate is the key thing here, whether the child needs intubation rather than the difficulty of the actual procedure. When you make the decision, the procedure is actually relatively straightforward, and we know we have a very low complication rate when we do decide to intubate. However, along with that, you then have all the differences in the drug doses and things like that. And we know that classically children or babies have big occipits, and so when they lie flat on their back, they'll naturally bend their head forwards and naturally obstruct their airway more. They have things like these large floppy epiglottises we talk about all the time, and there's lots of differences that you can read about and list, but I think the main thing is to really think about how do each of those differences make a difference when you're doing a procedure or thinking about putting a blade in and trying to get a view of the cords. And I don't think we should make a massive deal over it, but it's worth thinking, I don't think when you're intubating a 2 or 3-year-old pre-hospitally, it's not the time to start grabbing a Miller blade if you're not used to using a Miller blade. Go with what you know, make it familiar, and do the basics well. And I think the other thing to think about in paediatrics is often the airway is very easy to manage with basic manoeuvres. So you can get a good seal with a bag valve mask with 2 people. You can put in an oropharyngeal airway and relieve airway obstruction. It's very easy to do a jaw thrust so basic airway manoeuvres are generally easy on a smaller child compared to, say, an adult or a 90-year-old. So I think that's why we don't always have to intubate based on traditional decision-making in adults. And the main reason we tend to intubate in kids is if the breathing is not adequate rather than as an airway obstruction, because on the whole, the airway is reasonably easy to manage with basic manoeuvres. And also if they're smaller and you think they're going to vomit, then again, it's quite easy to turn them over and suction them and drain and sort of stop them from aspirating. So it's a slightly different decision-making process joined along with all these little anatomical variations that we sort of go through. And just bearing in mind these sort of things. So, everything's a bit smaller. So we need to pay meticulous attention to the tube sizes so that we get the biggest tube we can do, but again, not too big that it causes damage to the delicate structures of the airway. We need to think about the positioning of the patient. So because of their big occiput, put something underneath their shoulders so that you get them into a nice neutral position to intubate. So I think it's not something to get hung up on, but something to be aware and to think about how you might slightly change the way that you're doing what you normally do because it's a smaller child.
So you mentioned breathing, Anna. So let's just double click on breathing and ventilation. Could I get you to speak to how providers and staff assess respiratory rate, effort and effectiveness in children, and maybe some of the common signs or red flags in your mind for respiratory distress or failure?
So let's imagine you go to a 56-year-old with a head injury who's got a GCS of 6. Now, within our service, that would be a fairly easy decision to do a pre-hospital RSI for neuroprotective strategies and to control their end-tidal CO2 for their head injury. Now, in children, the question I always ask when I'm thinking about whether I should be intubating a child or whether I'm called on call about whether we should be intubating a child is the breathing normal? Because we know that children look after themselves pretty well, for want of a better term. So they control their end-tidal CO2 pretty well for their intracerebral pressure. And it's only when the ventilation becomes impaired that they're then not able to do that. And I think that is the key point where the risk versus benefit, so the risks of intubating a small child in an unfamiliar environment with the inherent risks that entails, because it's not without risk. We don't do many pre-hospital intubations on under 5 years old. I don't think anybody does. And in hospital, you have to be a specialist paediatric anaesthetist to intubate very small children frequently. So it is definitely a risk-benefit scenario. And I think only when that threshold is met, that the ventilation is impaired, they're having apneas or the ventilation isn't adequate, does that risk-benefit ratio then tip into the benefit of actually doing a pre-hospital RSI? So it's a slightly different decision-making process. It is not quite so black and white and straightforward as it would be in an older adult. But the beauty, again, of paediatrics, I keep using that term because they tell you what's going on. So they may well not have rib fractures because their ribs are traditionally much more bendy and their bones are far more bendy. So with the same sort of insult that would fracture ribs in you and I, the child may not get associated rib fractures. However, what they will show you is that if they have respiratory distress, you will be able to see it. Because their chest walls are that much more compliant, we've all probably seen it in bronchiolitic babies or asthmatics. The recession they get, the subcostal recession, the intercostal recession, the tracheal tug is very obvious. And so you can actually see the respiratory distress in front of you, which is slightly different and far less subtle than in an adult. You know, sometimes in an adult, you don't always pick up these signs straight away. You know, sometimes you think, well, perhaps they're breathing fast because they're in pain or distress. But in a child, if they're working hard, you can see it. And so actually it's a lot easier. But just remember that these small babies have far less type 1 fibers in their chest wall. And the type 1 fibers are the ones that are fatigue resistant. So they can only go on for so long before they get exhausted. So, and you can see when you see a baby working hard, it's hard work. They're really going for it. But again, so yes, if you can see that increased work of breathing, high respiratory rate, lots of recession, then you know there is a definite problem somewhere in the chest or in the airway that's causing obstruction. The other thing to think about is with tubes and things, they're all a lot smaller. And we know that any reduction in the radius of the tubes, so for example, the endotracheal tube or in hospital in a chest tube, reduces the flow significantly. So meticulous attention to detail and regular suctioning, making sure that the tube isn't blocked by blood or a clot or mucus in the case of medical patients is really, really important, because any decrease will significantly impede the child.
So let's look at circulation for a minute, and could I get you to speak to really around what are the best practices for assessing circulation and perfusion in children, particularly when obtaining a blood pressure and/or pulse is extremely difficult in this sick cross-section of children?
Yeah, so I think we all remember from our physiology that babies and kids notoriously compensate well until the very last point. So they tend to have good blood pressures, and blood pressures are often normal and reassuring till quite late in blood loss. And they compensate through high sympathetic tone. So that means they increase their heart rate, they vasoconstrict, but actually small babies can't change their stroke volume as you and I usually would. So remember, blood pressure is heart rate times stroke volume. And young babies have a relatively stiff heart with low ventricular compliance when they're small, and so can't have that subsequent increase in stroke volume. So all they can do is vasoconstrict and increase their pulse. So look at that pulse carefully and think about it. And if the pulse is raised and the baby isn't distressed, then there's got to be a reason for that. And it may be that you're missing blood loss. The other thing that I think is really useful is you can try a blood pressure by all means. It may or may not give you some clues. It may or may not read easily, but feel the baby or feel the child with the back of your hand. What's their temperature? Yes, if they've been exposed for a long while, they might be chilly around the edges, but what are they like centrally? And then the most important thing that I find that I use all the time in my paediatric practice is capillary refill time. And I think that is possibly the most incredible extra tool that you have available to you in peds, because it just tells you so much. And that is, just to refresh ourselves, press centrally, so over the sternum for 5 seconds, so 100, 200, 300, 400, 500. And the pinkness should normally return within 2 to 3 seconds. What's more useful rather than an actual value, because again, it's a slight estimate because you're doing it in your head and not on a stop clock, is an abnormal range. So if it's over 3 seconds, you know you've got a definite problem. And actually, I use the capillary refill time to guide my transfusion practice. And so when I'm transfusing a small child, I repeatedly do the capillary refill time just to guide myself so I can get an idea of where I am in terms of volume repletion. I think the other thing to think about in circulation is access for these children and how you're going to establish that. And again, that can be trickier, particularly in a volume deplete child. I think in the smaller children, don't underestimate the power of an IO, of a well-placed IO. I think we used to think that was sort of a poor man's IV access, but actually you can, with a well-sited IO, you can give large volume blood resuscitation through it effectively with a good setup of a fluid warmer, a 50 ml or a 20 ml syringe, depending on the size of the child. And you can give a balanced transfusion with a plasma and a blood attached to the other side of the fluid warmer. And you can actually, we found that we can actually get good volumes into these children. The other thing to think about is most pre-hospital providers don't have specific large bore access made specifically for children. And in fact, quite a lot of hospitals don't have that sort of equipment down in ED. And you can kind of make the most of what you have. And I say that again, when you're wanting to get big access in a really sick 2-year-old, it's not the time to try out central venous access in a place that you're not familiar with. So go with what you're familiar with and use things that you usually use. So in a small baby, something like a green Vigon arterial line can be useful to put in as a venous access, and just be careful with the length that you're putting in. When we get a bit bigger, we now advocate using our 4 French catheters that we use for Reboa, again, either in a femoral or a subclavian access, and just watching the line. So you can use things that you have in your kit and put them in places that you're familiar with doing. So to be able to establish appropriate large bore vascular access in these exsanguinating smaller patients. The other thing that I think is really key is when you're doing your assessment of the airway, breathing and circulations we've just talked about, is your meticulous attention to detail when you're examining the patient, so that you do find any findings that are actually there. I think sometimes, I certainly do it myself occasionally, is you have learned these examinations and they're so ingrained in your practice that you're examining a patient and you're doing your thing and you finish the examination, you're like, I don't actually know what I found because I wasn't concentrating 100% when I was feeling the rib round here or listening totally to the heart sounds when I was listening. So I think you can come away from an examination sometimes without much information. And I think the thing you have to do in children is examine with intention. You need to imagine that your hands are the CT scanner and that you're trying to find every single injury, because we know that in kids, because they have less body fat, their ribs are more compliant, their internal organs in their abdomens are not as well protected by the rib cage, so they're more exposed and they're more prone to injury. We know that injuries that you find are generally significant. So this is not written down in a medical textbook, but pretty much every time that you see a large abrasion on the abdomen over the spleen, then when you CT the child, there's a splenic injury. So I always say that actually things you can see on the surface are really significant and generally represent something that's injured below as well, because of the physiology and body habitus of these children.
Yeah, I really like that, Anna. I really like the fact, as you said, just assessing with intention and paying meticulous attention to subtle signs, because in the fruition of time they can become extremely abundantly apparent, but it is in the pre-hospital phase of care, at close point to wounding or indeed injury, some of these signs are far more subtle, and it's prudent to pay attention to that. So just pivoting slightly and looking at the neurological assessment, could I get you to speak to your thoughts around assessing a child's level of consciousness and tools that actually serve us well and maybe support our cognitive processes rather than complicate it?
I think if you're faced with a sort of a low GCS baby, the last thing you need to be doing is trying to apply a non-familiar complex scale of paediatric GCS. I think I'd go as far as to say I absolutely hate it, and I don't think I've ever used it properly. And it's just it's not what you need in that moment. And so I'm very much on the side of the AVPU scale. It's familiar. It's easy to do. We've all done it multiple times. It's quick. The thing I would say is within the paediatric GCS, the useful thing to do is to write down or to just note what is the baby or child actually doing. So is there that abnormal cry? Are they doing abnormal posturing? What does that abnormal posturing look like? And then we can put that together at a later stage, because actually all these things are really quite useful for the neurosurgeons when you get to hospital to help guide management and decision making. So it's not to say that these GCSs aren't important. It's very difficult to do in the heat of the moment. So try not to get too hung up on exact numbers of the GCS, but the descriptions are far more useful. And the other thing is the worry that actually you interpret what you're describing as the wrong number, and then that gives the wrong message anyway. So I would not use a formal number on the GCS. I would stick with AVPU with descriptions of what the child or baby is doing. I think the other thing to think about in smaller babies is fontanelles. We often forget about those. Babies are born with 2 fontanelles. The anterior one, which is at the front of the head, closes between 12 and 18 months, and the posterior one is open up till about the age of 8 weeks old, so closes much quicker. But if you've got a 9-month-old, then do feel that fontanelle, particularly when they're not crying. When they're crying, it bulges as well. But actually, if you've got an unconscious child, then feeling that fontanelle can give you a clue as to what their intracerebral pressure is doing. These smaller babies don't tend to cone from head injuries in the immediate phase, because they have somewhere for the pressure to escape through the fontanelle. So it's just worth bearing that in mind as well.
So just pivoting and looking at pain assessment and management in paediatric patients, could I get you to speak to some of the management and concepts that really you enact on scene when managing pain in paediatrics, and maybe indeed some lessons learnt from your practice?
Yeah, there seems to be sort of a slight ingrained reluctance to give children lots of opioids. I think we're either scared or worried that we're going to overdose them and they're going to stop breathing and things on us. But actually, a child who is screaming in pain puts everyone's blood pressure up, and it is the one thing that you can do to improve your performance and to just bring the tempo down of everything on scene, and all of the anxiety is to get that child pain-free or reduce their pain as much as you possibly can. And it's the same as in adults. But I think the most important thing is to sort of think about all the other things you can do other than just push in a whole load of morphine. So again, we've talked about facial expressions, and I think, it's natural to spend the whole of the time you are with a really sick patient looking understandably concerned. But actually, if you can think about your facial expressions, how you speak to the child, make sure if they're immobilized, they can actually see you, talk calmly to them, use their name, get somebody in to hold their hand. If they haven't got a parent or a family member around with them, get somebody else to hold their hand, get that rapport going. And I think there's a huge amount to be said for that subtle analgesia of having somebody reassuring you and calming things down. I then always advocate a dose of oral analgesia if they're in an appropriate state to receive that. Obviously, if their GCS is reduced and they can't take oral meds, then don't do that. But actually getting in a dose of paracetamol or IV paracetamol nice and early will help build up this sort of pain ladder of analgesia, and will also have a nice base layer to the analgesia as you go through the hospital stay, or go through the A&E stay. And so I don't rule out paracetamol. I'd get that in nice and early. And then you've then really got 2 options. You've either got intranasal or intravenous, or both actually. And what I tend to do is give them a dose of intranasal opioids, so that'd be that fentanyl or ketamine, nice and quickly, because I don't need IV access or anything for that. And it immediately provides that anxiolytic and analgesic effect to calm things down and make the child feel better. And once I've got a little bit more control with the intranasal, I can then more slowly get decent IV access and then follow that up with some IV opiates. And I'm a massive fan of fentanyl for these children. It works nice and quickly, it's nice and clean, and it provides great analgesia.
Anna, could I get you to speak to some common pitfalls that you see quite commonly on scene that potentially get missed? I think through the adage of time, the salience of landing in a helicopter on scene with all the frenetic activity, there is some of these details which can get missed over time. Could I get you to speak to those?
Yeah, absolutely. So I think the main one that we're all guilty of is temperature control. So we've talked already that children have less subcutaneous fat than adults. So they've got a larger body surface area to weight ratio. So they get cold really quickly. And the trouble is we go along and expose these patients so that we can see the injuries, we can examine them carefully. And then we're all trying to do stuff to the critically unwell child, be that IV access or putting on a pelvic splint, which all involves the patient to be exposed so that we can get everything done as quickly as we can. But that leads to heat loss. And it's very difficult to warm that child up. It's much easier to lose heat than it is to regain it. And so just meticulous attention to detail of minimizing that exposure, particularly when it's cold, getting the child under blankets and off the road, off the cold, into the ambulance as quickly as you can, I think is really, really important. We all know that temperature and cold patients become more coagulopathic, and it's not good for you. So maintaining that body temperature is something just to think about, not at the expense of doing all the procedures, but just at the back of your mind. The other thing to think about is in these smaller kids, they have relatively small glycogen stores compared to us. So under stress, they use up their glucose reserves very, very quickly. So they can become hypoglycemic. And I guess that's the last thing on your mind when you're trying to deal with these children, but it is worth just checking their blood glucose. And if you need to replace that, then it's twice the age in mils of 10% glucose is a good way to just think about how much you need to give to them. And obviously, we can't talk about paediatrics without addressing safeguarding. Again, we could chat for hours about safeguarding and all that entails. I think the thing that I've learned over the years is that all of that can generally be done later. So I think you need to be careful about making definite judgments on scene and limiting access of parents to children based on what you think might have happened until the facts can be established. Safeguarding is obviously a huge part potentially of paediatric trauma, but there are processes and pathways that can be followed later. And I think if there's any doubt, then don't judge in the moment and just go with the practice that you would normally do. I think the other big thing to consider is also, you're not only going to these small babies that we talk quite a lot about, but also when you approach a 14 or 15-year-old girl who has trauma, if she's awake and able to talk, if you just go and start cutting her clothes off, that's just never going to work. She's going to be very aware of exposing her in the middle of a public place. And so you just need to be mindful and slightly adapt your approach, explain what you're going to do, make sure you've got a blanket ready, keep her dignified, keep her modesty intact if you possibly can. And all of these things will allow the patient, whether they're 3 or 15, work with you, which I think is the really important thing. Gain their trust, and then it all becomes a lot easier.
So let's go to a topic we haven't really touched on yet, that of family interaction. Can I just get you to speak to some of the take-home messages really that you enact and or use with families to really bring them along on that journey, keep them involved, keep them updated, but also try and instill some semblance of calm and, I guess, reassurance?
Yes, I mean, I think it's obviously horrific for any parent to see their child injured or significantly unwell. And you almost have a second patient when you've got a parent or parents on scene or a close family member. They are your fiercest critic. You are treating the most precious thing in the world, and they are anxious and scared. And my line is generally to try and keep them with the child if at all possible. I think that hand-holding is key. If they are creating difficulties with you being able to give the treatment that you're wanting to give because they are so upset, then I think there is a time and a place to say, I'm going to get you to stand over here so I can concentrate on giving really good care to your daughter or son. But I think if you can, or at least for some part of the time you're with the patient to get mum or dad in, to see them, to hold their hand, give them a kiss, things like that, I think really make a difference. The conversation I tend to have with parents is I go and speak to them. I introduce myself and I explain what's happening. I say, I know this is the worst thing that you can ever possibly imagine. The way that we're going to get through this is just to think about it in 10-minute slots. We're not thinking about tomorrow. We're not thinking about 2 weeks down the line. We're thinking about getting through the next 10 minutes. And in the next 10 minutes, I want you to go into the house and I want you to get any medications. I want you to pack a bag with some things you'll need at the hospital. And then I want you to come back to this police officer and we will look after you. We will then give you what to do in the next 10 minutes. So it becomes a manageable amount of time and a way to actually function in this most horrific scenario that these people have found themselves in. And that 10 minutes at a time, having spoken to people afterwards, people find that quite useful because it's a manageable amount of time to not thinking about anything else. I'm thinking I can get through 10 minutes. We can all get through 10 minutes of whatever that 10 minutes is going to show. And then we can think about the next 10 minutes. And I found that quite useful, not only with parents, but also with relatives of critically injured and unwell patients.
I know, that's fantastic. It's just great to get your thoughts and indeed perspectives over this last half an hour. Listen, thank you so much for joining me on the podcast. It's been a real pleasure just to have you on.
Absolute pleasure. It's been fantastic. Thank you so much and great to see you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.